Welcome to our channel, Medicine A to Z. Today we are going to discuss idiopathic pulmonary fibrosis. Stay informed and up to date with the latest medical knowledge. Subscribe to our channel. Definition: Idiopathic pulmonary fibrosis is defined as a spontaneously occurring specific form of chronic fibrosing, interstitial pneumonia, limited to the lung, and associated with characteristic usual interstitial pneumonia patterns on high-resolution computed tomography, HRCT, and lung histology. Idiopathic pulmonary fibrosis, IPF, is a type of restrictive lung disease where the lungs cannot expand properly. Restriction can come from outside the lungs, extrinsic, like neuromuscular issues or pleural effusion. Extrinsic restrictive lung diseases are discussed in our hypersensitivity pneumonitis video. Intrinsic causes occur within the lungs and can be interstitial, between the alveoli, or diffuse non-interstitial. Interstitial lung diseases include allergen-induced conditions like organic and inorganic pneumoconiosis and hypersensitivity pneumonitis. If the cause is unknown, we categorize them as idiopathic interstitial pneumonias, IIP, which can be chronic or acute. Chronic IIPs include idiopathic pulmonary fibrosis, IPF, and nonspecific interstitial fibrosis, NSIP. Today, we're focusing on IPF. Epidemiology. Interstitial pulmonary fibrosis typically affects people in their 6th and 7th decades of life. The incidence ranges from 3 to 9 cases per 100,000 people per year. IPF is a specific form of chronic, progressive, fibrosing interstitial pneumonia of unknown cause, primarily affecting adults and confined to the lungs. The underlying lesion in IPF may exhibit more fibrosis than inflammation. It is the most common spontaneously occurring diffuse parenchymal lung disease and was previously known as cryptogenic fibrosing alveolitis. UIP versus IPF. UIP, or usual interstitial pneumonia, refers to a specific histological and radiological pattern found in interstitial lung diseases. It's important to note that UIP is not a disease name itself, but a characteristic pattern. A radiographic or histologic finding of UIP can occur in non-idiopathic interstitial lung diseases, ILDs, meaning it's not exclusively linked to the clinical diagnosis of IPF. The exact factors that trigger the histopathologic processes seen in idiopathic pulmonary fibrosis, IPF, remain unknown. Several risk factors are associated with IPF, including cigarette smoking, viral infections, environmental pollutants, chronic aspiration, genetic predisposition, and certain medications. A genetic predisposition to idiopathic pulmonary fibrosis, IPF, exists, with several genes identified in patients with familial pulmonary fibrosis. These genes are associated with surfactant proteins and the maintenance of telomere length. Pathogenesis. Repeated micro-injuries to the alveolar epithelial cells can cause fibrosis. The growth factors and cytokines released by these damaged epithelial cells then recruit and activate fibroblasts. Activated fibroblasts then multiply, and some transform into myofibroblasts, boosting collagen synthesis while reducing its breakdown. This leads to abnormal collagen production. The abnormal collagen, along with clustered mesenchymal cells, forms fibrotic areas. Progressive deposition of extracellular matrix leads to distorted pulmonary architecture with loss of capillary surface area and gas exchange units. The resulting honeycomb fibrotic lung has no potential for regeneration and repair. Clinical manifestations typically present at age 60 years or older. The symptoms include gradual onset of dyspnea, difficulty breathing, on exertion and non-productive cough over several months, rare occurrence of fatigue, fever, myalgia, muscle pain, and arthralgia, joint pain, presence of basilar crackles, crackling sounds in the lungs. In most cases, although they may be absent or heard unilaterally in early stages of the disease, in more advanced stages, end inspiratory squeaks may be present due to traction. Bronchiectasis. When taking a patient's history for idiopathic pulmonary fibrosis, it's important to consider several key factors. Exposure to potential triggers such as asbestos, silica, other fumes, vapors, dusts, or mold should be explored. Additionally, inquire about any history of medication use, particularly drugs like amiodarone, bleomycin, long-term nitrofurantoin, or biologic therapies. Family history plays a crucial role. Look for a family history of interstitial lung disease, ILD, premature graying, cryptogenic cirrhosis, aplastic anemia, or other bone marrow diseases. Be attentive to signs or symptoms suggestive of rheumatic disease, such as joint pain or inflammation, digital ulcers, dry eyes, dry mouth, fatigue, fever, hair loss, muscle weakness, or pain, photosensitivity, Raynaud phenomenon, skin thickening, or telangiectasia. High-resolution computed tomography, or HRCT, should be obtained in all patients suspected of having idiopathic pulmonary fibrosis, or IPF. In IPF, HRCT features should align with those of usual interstitial pneumonia, or UIP. Classic HRCT features of UIP include reticular opacities, which appear as a network of lines or streaks, typically in a basal and peripheral distribution. Traction bronchiectasis, characterized by dilated and thickened bronchi due to fibrosis. Honeycombing, which consists of clustered air spaces ranging from 3 to 10 mm in diameter, often in a subpleural location. Ground glass opacities may also be present, but are usually less extensive than reticular opacities. Based on the presence and extent of these features, an individual patient may be categorized as considered UIP, probable UIP, indeterminate for UIP, or suggestive of an alternate diagnosis. Histology. The histologic hallmark and chief diagnostic criterion for UIP is a heterogeneous appearance with alternating areas of normal lung, fibrosis, fibroblast foci, and honeycomb. BAL or bronchoalveolar lavage. BAL has a limited role in the evaluation of patients with suspected IPF, largely to identify alternate diagnoses such as sarcoidosis. Unlike bronchoalveolar lavage from normal controls, BAL from patients with IPF contains increased amounts of transforming growth factor beta, TGF-beta, including the active form TGF-beta 1. It's important to note that there is no specific diagnostic laboratory test for idiopathic pulmonary fibrosis, IPF. However, laboratory testing plays a crucial role in the diagnostic process by helping to identify or exclude other processes in the differential diagnosis. Serologic tests can be particularly useful in this regard. They aid in identifying underlying rheumatic diseases and hypersensitivity pneumonitis, both of which can present with similar clinical features to IPF. Diagnosis of IPF requires exclusion of other known causes of interstitial lung disease, ILD, and either definite or probable features of UIP on HRCT. Multidisciplinary discussion, MDD, is considered the gold standard for diagnosis. When the results of the clinical evaluation, laboratory testing, and HRCT do not allow the clinician to make a confident diagnosis of IPF, cerebral lung biopsy or transbronchial cryobiopsy may be indicated. Treatment for idiopathic pulmonary fibrosis, IPF, focuses on various aspects of supportive care and management. Supportive care measures include the provision of supplemental oxygen to relieve dyspnea and improve oxygen levels in the blood. Pulmonary rehabilitation programs can also be beneficial in improving exercise capacity and quality of life for individuals with IPF. In addition to supportive care, vaccination against COVID-19, pneumococcal infections, and seasonal influenza is essential to prevent respiratory infections, which can exacerbate IPF symptoms and lead to complications. It's crucial to provide information about end-of-life issues and advance directives to all patients with interstitial lung disease, ILD, including IPF. This helps ensure that patients' wishes regarding medical care and interventions are respected and followed. For patients with mild to moderate IPF based on pulmonary function tests, who live in areas where either pirfenidone or nintedanib is available, these antifibrotic medications may be considered. Both pirfenidone and nintedanib have been shown to slow disease progression and improve lung function in patients with IPF. Nintedanib, an antifibrotic agent, is typically prescribed at a dosage of 150 mg taken orally twice daily. However, it's important to note that patients with liver disease, specifically those classified as Pu-B or worse, or those requiring full anticoagulation, are not suitable candidates for nintedanib therapy due to potential risks. Common side effects of nintedanib include gastrointestinal symptoms such as diarrhea, nausea, vomiting, and elevation of liver function tests. These side effects are important to monitor and manage during treatment. Both nintedanib and pirfenidone have shown efficacy in reducing the decline in lung function in patients with idiopathic pulmonary fibrosis, IPF. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.